Hello, and welcome back to The Vitals, the Mount Sinai Health System's podcast exploring the people and innovations advancing medicine today. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. Today, we discuss the rising rates of colorectal cancer, particularly among younger adults. It's an issue that's received increasing attention in recent news and in the medical community. Colorectal cancer was once thought as primarily a disease affecting older adults, but historic numbers of patients are finding themselves with a diagnosis in their 30s and 40s and sometimes even younger. Today we'll talk about why that might be happening, what symptoms people should pay attention to, when to seek screening, and what happens if a screening test reveals something concerning. To guide us through this, we're joined by three of Mount Sinai's experts, Drs. David Greenwald and Dr. Pascale White, who are both gastroenterologists, and Dr. Deirdre Cohen, who is a medical oncologist treating colorectal cancer. Thank you so much for joining us. Welcome. Okay, so we've been hearing lately that colorectal cancer has been affecting younger patients. I've seen it in the news like Instagram and TikTok, but what trends are you guys seeing in your practice? Are you also seeing it in younger patients?
Absolutely. I think the one thing that really struck me in the past couple of months is the new JAMA article that came out that said colorectal cancer is now the number one cancer-related death in patients under 50 in the United States of America. And this tracks with what we're seeing in our endoscopy practices, patients who are coming in with symptoms in our clinics and saying, hey, this could be a hemorrhoid. I'm saying it very well could be something like a hemorrhoid that's benign, but we're seeing trends with younger people being diagnosed with this disease, and so we need to check it out.
Why? Why is this happening? What do you think is the reason?
Long and short, we don't know. There are different things that we're thinking about at this point. Could it be environmental? Could it be the microbiome? Could it be early antibiotic exposure? All these things that we're trying to look into at this point. But the long and short of it is that we're working really hard to figure out what's happening.
Okay. So obesity has also been blamed.
Absolutely.
And diet. But again, there's no real hard evidence to explain it, but it's definitely a trend that we've noticed. And the bottom line is that if you're under 40 or 45 and you have a symptom like rectal bleeding, it needs to be checked out, not just sort of said, oh, it's probably a hemorrhoid, this is nothing, or it'll go away. But definitely come seek healthcare professional guidance and probably some sort of investigation to understand why it's there.
We did a podcast a couple months ago on the Surgeon General's update for alcohol, with colorectal cancer being one of the cancers that you're at increased risk if you drink alcohol. Do we think that alcohol is to blame for this? Maybe is alcohol been on the rise?
So alcohol is a risk factor for colorectal cancer.
Yeah.
There are a lot of things that are risk factors. The most important risk factor for colorectal cancer turns out to be advancing age. So although you just mentioned young people, again, just the simple fact of getting older is the most impactful reason for getting colorectal cancer. Alcohol itself, there are other risk factors. We think a diet that's increased in red meat or processed meats, cigarette smoking, all of those are risk factors for colorectal cancer.
So cigarette smoking is also a risk for colorectal cancer?
Yes.
I want you to know I know the answers to some of my questions. I didn't pretend like I don't.
There are a zillion reasons. There are a zillion reasons why cigarette smoking is bad. This is one of them.
Okay. And you guys are seeing the patients, symptomatic, they come in. We'll get back to diagnostics and stuff, but you're treating these patients.
Correct.
What would be your guess if you were to name your belief for the top 3 reasons why younger people are getting colorectal cancer?
I think it is probably a lot to do with diet, early exposure to antibiotics, and then the sedentary, lifestyle that we are seeing. So, but again, I think to prior point, we don't really know. These are all hypotheses, but I think that they're gaining more and more ground.
Right. The early exposure to antibiotics. Can you guys just go into more detail? Because this is the first time I'm hearing of this.
Well, I think it's more about changing your microbiome, right? So we all have bacteria that live and breathe, or not breathe, but live on us, with us, and they play a huge part in health and disease. And there can be alterations in that the communities of bacteria that can lead to dysbiosis, and ultimately it's downstream effects in terms of immune function and allowing cancers to develop. So chronic inflammation is part of it.
So really a community disruptor.
Yeah.
Your
It can be a community disruptor. I just want to put a little plug in for the use of antibiotics when they're necessary.
Okay.
So and I know you would agree with that. Antibiotics are really important in fixing certain bacterial infections that can be very serious. So this is not to say that all antibiotics are bad, but they have to be used judiciously and properly.
Well, then do you guys have like
agree.
a GI or
that.
probiotic for when you're on antibiotics?
You're not gonna catch me there.
So like, do you tell people to take probiotics or just like have yogurt, kefir? Is that like a thing?
No,
Really?
just in terms of prevention, no.
Why mind blown?
I don't know, because I feel like out there in the world, they tell you to take I don't know who they are right now. Like they is, I don't know, Instagram and TikTok.
That's
They
right.
tell you to take probiotics and you think you have to, but you are telling us no.
So the evidence is very weak to non-existent, depending on what you're looking at, for the use of probiotics for when you're taking antibiotics or for irritable bowel syndrome in general. Very, very weak. So yeah, TikTok and Instagram say that, but you got to go back to the scientific evidence.
So this is why we actually have this podcast, to say exactly these things. All right.
So and the probiotics don't necessarily hurt people.
Just the wallet.
They cost money. That's exactly right. And that's exactly what I say to my patients, which is this is not going to hurt you, but it's going to separate you from your money. Yeah. And they understand
with that. Yeah. Sometimes it feels good to put probiotics in, even if you know you're throwing your money out the window.
It's up to you.
Okay. Yeah. All right. So let's go back to diagnostics. You said if you have a symptom to come in and get checked. So like you said, rectal bleeding. What are some other symptoms that you can look for?
Yeah, abdominal pain that is prolonged, and we're not talking about the run of the mill. If you went out to eat something and you get a little sick and you have a couple, a bellyache for 1 or 2 days. We're talking about patients who have like chronic for weeks or months on end abdominal pain. Patients who have weight loss that they're not intending to lose. They're patients who, you mentioned rectal bleeding. They're patients who have a change in what their stool looks like. Right? We call it a change in caliber of stool. So if it looks pencil thin, if it looks smaller than usual, or even if your bowel habits have changed. For example, if you're going too often or having looser stools, or if you're not going off more often enough, like if you're having constipation, these are all things that are off your baseline that you really want to have checked out with your physician.
So you had said that obesity is also a risk factor for colorectal cancer. And now there's medicines out there like all these GLP-1s, right? Upside of GLP-1, hopefully we see a decrease in obesity. Downside of GLP-1s, change in stool character, change in symptoms. What are you guys seeing with that? Are you guys seeing patients coming in trying to figure out what's what?
Yeah, so it's a great question, actually. So we've actually talked about this a couple of times. The GLP-1 agonists and other similar drugs, are incredible for weight loss. The part of the way they work is they slow down the GI tract, the stomach, and the colon as well, mostly the stomach. But so constipation and change in bowel habits is pretty frequent. And the concern now is whether people who have some of these early warning signs that Dr. White was just talking about and are taking GLP-1 agonists or similar drugs are going to confuse the two of them and delay their diagnosis. I don't know that we know that that's happening just yet, but it's certainly a possibility and something we have to be aware of.
Yeah, I've been on GLP-1s. I have a lot of patients on GLP-1s, and it's like the constipation is real.
Yep.
Yeah, it can be actually pretty scary.
Yeah.
So back to the blood in the stool. So is blood in the stool like the number one sign of colorectal cancer? Because I feel like that's what we hear.
I mean, it's a sign. It could be a number of things. And patients say blood in the stool, does it matter the color? Does it matter how frequent? I always say to my patients, it's never normal to see blood in the stool. It could either be from a completely benign or just non-dangerous cause like a hemorrhoid or a little fissure or a cut around the anus, or it could very well be a bleeding, polyp or malignancy.
How can you tell the difference?
We can't, which is why we always say when you have a symptom, talk to a provider, come in, have us check it out with
Do you need a colonoscopy to evaluate blood in the stool, or is that something that you guys can figure out on just an exam?
We need a colonoscopy. Yeah, we need a colonoscopy. Some patients say, can you do a rectal exam? I'm like, I can do a rectal exam, but that doesn't mean whatever is bleeding right now. And so whatever bled at that point may have stopped, but we need to check it out with a colonoscopy, with a camera study.
Can you now walk us through what the options are for colorectal screening?
Sure. So there are a variety of options, which is really good. At Mount Sinai, we talk about choice because there's a choice in colorectal cancer screening options. In fact, our colorectal cancer screening program is called CRC Choice. Anyway, those choices include looking for blood in the stool typically called an FIT test, or fecal immunochemical test, which is looking for blood in the stool. A test that looks for blood in the stool and abnormal DNA, which are little pieces of cells that might be coming off of polyps or tumors. That's called FIT DNA. It's marketed commercially as Cologuard. Many people know about it. And then there's colonoscopy, which has become the gold standard over many, many years now, because it allows us to both detect abnormalities like polyps, which are little growths, and remove them at the same time to prevent cancer. There are a couple other options. There's a CT colonography, which is a CAT scan of the abdomen, which is reconstructed into a kind of a video that looks like a colonoscopy. And there's a capsule, as you described, which is exactly what it sounds like. It's like a little magic capsule that's got a CCD chip, like a digital camera chip in it, with an antenna and a battery and some lights. And when you swallow the capsule, the battery turns on, the lights turn on, the camera turns on, it starts to take pictures. There's also an antenna in there that transmits those images wirelessly to a belt recorder, a hard drive, and then eventually the capsule goes in the toilet. The hard drive comes back to us. We download the images. You do not have to fetch the capsule, which is terrific. And then we look at those images, and it gives us essentially a different view, just like a colonoscopy.
So they're like little,
options.
little bomb robots that you send into a bomb room to look but not be there.
Super cool if we could put little scissors in there and then snip the polyps out, but we hadn't gotten there yet.
Can I ask, what are your guys' thoughts about ctDNA in terms of screening?
You talking about blood testing?
Yeah.
Yeah, so I was just going to get to that. But yeah,
sorry.
blood. No, that's fine. Yeah, so blood testing is also now available for testing for colorectal cancer. There's one that's FDA approved. There are some others in the works, and there's another version of it also as well. But they are terrific right now at screening for cancer. They are not as effective by any means at screening for polyps. And since we know that in colorectal cancer, there's a precursor lesion, an early lesion called a polyp that's not cancerous. And if we take it out, people don't get cancer. So that's, to me, is sort of where we're going with this. So
if you had like a negative screening test, you could safely think you're okay, but you're not.
If you had a negative blood test, for example, you probably don't have cancer, but you may still have a polyp, and we want to get to those polyps. It's the same thing with some of the stool-based tests, actually.
So isn't there like...
Great question.
What's the blood test that you can screen for cancer? What is it called?
Grail.
Well, there are
multiple. There was like, when I was in PA school 20 years ago, there was a blood test for screening.
Yeah, that was called Septin 9. It's sort of fallen out of favor. These other tests that we're talking about now are much more sensitive and specific than those early tests. But they've still got, I think they've got a ways to go.
Well, no, that's
Do
why
you
I
agree?
wanted to ask my gastroenterology friends what your thoughts are on blood-based testing, although I suspect in the next 5 to 10 years that there may be far fewer colonoscopies done.
And that, I think that would, I mean, Dr. White can comment, but I mean, that would be fine with us as long as the sensitivity and specificity, which you talked
we're not there yet.
to try, are perfect or good enough that we're not missing anyone along the way. So yeah, we'd be good.
Blood work can't clip the polyps, though.
Well, we would love to get to a place where we could mass screen the whole population with a non-invasive test, like a stool test or a blood test, and then reserve the colonoscopies for the people, 30 to 40% of people right now who have polyps, who will benefit from that. So yeah, that would be terrific.
And I know patients much prefer to have a blood test than the stool. I'm sure you guys struggle, right, with having patients.
Yes. Yes. The idea of having, an invasive procedure or being put under sedation or anesthesia to some people.
No, she's talking about the stool-based test over a blood.
Oh, yeah.
Yeah, there's an ick factor.
This is like extra.
Are we talking about you collect it in a container and send it to a lab, or you go in for a rectal?
No. Collect it at home and send it to a
Sorry,
lab.
but I answered your question.
No, that's fine. I just think that it'll be a much bigger uptake. I feel like we could capture a whole lot of more patients for screening who are, concerned about colonoscopy and that prep, and then even just collecting stool at home, which is obviously far easier than a colonoscopy prep.
But we definitely
it's not ready yet.
Yeah, we definitely have to be careful. It can't be overstated, the fact that the blood tests at this point are not detecting early colorectal cancer, which when it's detected early, you have a higher survival rate, up to 90%. And so with patients who have early cancers, we want to find them and potentially have it cured, right? But these blood tests are not good at that yet.
So it's just one tool in the toolbox for right now.
Correct.
And do you use the blood test to follow patients?
Yes. we do.
Move. Okay.
Yes.
So once they're
for
in treatment,
surveillance,
we're getting to
for-
treatment, I promise.
Oh, that's fine.
It's a different blood test, though, that you're following.
It's a different blood test. Yes.
So what are the recommendations right now? Let's just talk about the general healthy public. Then we can talk about people that have like obvious risk factors, like, I don't know, ulcerative colitis or Crohn's, and then people with family history. So what's the screening recommendations?
So right now it's 45 for everybody. So we like to say 45 is the new 50 for patients who need to know that the age went down to 45 because we're seeing an uptick in early colorectal cancer. So it's 45 for all. And these are for patients who are at average risk. So patients who have no family history of colorectal cancer, patients who have no personal history of polyps, patients who have no symptoms at all. So they're not anemic, they're not losing weight or having blood in the stool. These are patients who are going to come in and say, I'm asymptomatic, average risk. We're going to screen you at 45. Patients who have any other risk factors, they're going to be screened earlier.
So for patients who have a primary care doctor, I know how our EMR works. Something will come across their screen saying, ding, ding, 45, send them for a colonoscopy. But like, how do you capture patients that like don't have their yearly PCP or follow their care? How do we make sure that they're getting it?
Okay, so there has been an enormous amount of work done on outreach to the public to make sure that this message is getting to everyone, and it's getting to everyone in different languages, in different populations, with different messaging to the different populations, because we know that the messaging that reaches one population won't necessarily reach the other. So there are national organizations that we're all involved in that have put together really amazing public relations information to try to get that word out that this is a preventable disease. Colorectal cancer is largely preventable if we can take polyps out. If it's not preventable, as Dr. White was saying, it's detected early, it's treatable, so it's beatable. And that's the message we're getting out there. So we have to just keep getting that message out. And having said that, the screening rate in New York City right now is about 69%, which means that 31% of the eligible population hasn't been screened. And around the country, it's not any different than that. And the rates are even lower in the groups that have lower insurance or less insurance or federally qualified health centers. The screening rates are in the 30s and 40% right now. So we've got a lot of work to do.
Is a colonoscopy, which is the gold standard, is that covered by patients who have Medicaid? Yeah.
Yes.
Absolutely.
So there should be,
with no copays and no deductibles.
Okay. Well, I guess this would be a good time just to like pause for a second. So if you are new to the vitals, please make sure that you scan the QR code below. We want to make sure that you guys follow us and get all this information moving forward. And hopefully, if you can't stay for the whole episode, also scan the QR code below to make an appointment to see one of our gastroenterologists if you're 45 or up and haven't had a colonoscopy. Okay, so let's keep going. So you have a patient, they're getting their colonoscopy, polyp, whatever. Can you tell right then and there during the colonoscopy whether that looks like something cancerous or not?
You can tell if something looks malignant most of the time. But because we don't know, we have to remove them and send them off to the pathologist, right? So if we're finding a big tumor, yes, some things are pretty obvious, but these polyps that we're taking out, we send them off to the pathologist to confirm if they're precancerous or not. Because not all polyps are precancerous. Right. There are some polyps that don't turn into cancers. Right. It's the precancerous ones that we want to find and remove.
And then the ones that have the precancerous, like the polyps, you just follow them more closely with colonoscopies moving forward?
It depends on the type of precancerous polyp. It depends on the size. It depends on the number we find. We have guidelines that tell us when to come back for these colonoscopies.
So now we have a patient with cancer.
Yeah.
Like what kind of cancer is colorectal cancer? Is it adenocarcinoma? What are we dealing with?
Yes, it is an adenocarcinoma, gland-forming tumor, correct.
Okay. And so what are the treatments? So is there surgery, radiation, chemo?
Yes, is the answer. It really depends. It's very stage dependent, right? So if it's a stage 1 colorectal cancer, for example, that's treated with surgery alone. So most of those patients never see me, which is wonderful. They have well over 90% survival rate. For stage 2, typically it's mainly surgery again. We do look at ctDNA to help us prognosticate their risk of recurrence and whether chemotherapy would be helpful to lower that risk of recurrence. But for the most part, stage 2 patients are not getting chemotherapy, and surgery alone is curing them. It's where we get into stage 3 and 4 where there's more multimodality therapy, including surgery, chemotherapy, and radiation in the setting of rectal cancer. So that's where we really use radiation therapy. And there is a distinction between, biomarkers within colon cancer. So, and certainly gastroenterologists can also, chime in here in terms of tumors that are mismatch repair deficient or microsatellite unstable.
Can you bring that down 5 notches for
Yes, so that is a
me and our
biomarker.
viewers?
It's basically a mutation that can happen either you've inherited it from mom or dad, and then it's called Lynch syndrome, or it's sporadic, and basically it's a error in DNA repair. But it actually allows for the tumor to produce more antigens. And so these tumors are much better behaving, and they also respond to immunotherapy, which I know is a big hot topic.
So once the pathology comes back and you can do some genetic workup on the actual tumor itself, you then can find out whether or not they're candidates for immunotherapy versus just like chemotherapy.
Yeah, so we do a lot of testing on the tumor to help us understand the biology of the tumor, so including whether they would be good candidates for immunotherapy and, what treatment they would best, need.
And this is way different than it was like 10 years ago.
Yes.
I mean, none of this even existed, which is so
like what
cool.
are
It's
the
much
biggest
more
differences?
personalized medicine.
Yeah.
So we're really looking and understanding what's driving the tumor and, having more targeted approaches. And we're also, backing off from some of our more aggressive therapies in that setting. So, for example, for mismatch repair deficient or MSI high rectal cancer, we're now able to treat these patients only with immunotherapy and forego surgery and radiation, which is huge in terms of quality of life and functional outcomes.
I know you're the oncologist, you're not the surgeon, but like you said for stage 1 and stage 2, surgery can be curative. Can you just tell us a little bit about what that is? Is that like a big surgery with a bag? Is it something smaller?
Sure. So typically, for colon cancer, they're taking out part of the colon, so a hemicolectomy, whether it's on the right side or the left side, and there's no bag involved. So they are, put back together, if you will.
Sniff, reconnect.
Correct. And they have complete, normal function. I mean, there's a little change early on, but generally people live a really full and, normal life following surgery.
Okay. And then, so is it like more of like because when I think colorectal cancer, I can't help it. I worked in urology for years, so I had patients with stomas. Like, who are the patients that are getting the bags?
Most of the patients with colorectal cancer are not getting bags unless they come in fully obstructed and blocked, and then the bag is actually a temporary measure while the rest of the situation is taken care of, and then eventually it's again the tumor will usually be resected, taken out, and then the colon reconnected in the vast majority
It's like
of patients.
a healing mechanism.
It's a healing mechanism, yeah. There are lots of patients who get bags for other reasons, diverticulitis and so forth, but in terms of colorectal cancer, it's pretty rare.
Yeah, I think, the only time would be a very low-lying rectal cancer. And even then, we're trying to avoid that with chemotherapy and radiation.
How long does treatment usually last?
That also kind of depends on the stage. So certainly for metastatic, it's sort of indefinite. It really depends also if there's limited metastatic disease, what we call oligometastatic disease, where we can surgically remove all of the metastases, versus if it's widespread and then sort of treatment continues until as long as patients tolerate it and the tumor's responding. But typically for stage 3, where it's surgically resected and there are lymph nodes that are involved with cancer, we give about 6 months of chemotherapy on average.
And do you have any clinical trials right now that are going on?
We do have several clinical trials going on. So we have a study looking at basically using ctDNA, which is circulating tumor DNA. So looking at sort of fragments of cancer cells or the DNA of the cancer cells in the blood and adjusting treatment based on that. So escalating treatment if the ctDNA is positive in the blood, or de-escalating if it's negative. So really trying to avoid over-treating patients who are going to be cured with surgery alone and avoiding chemotherapy, because certainly chemotherapy can have some long-term side effects. And then escalating, trying to cure more patients who, may benefit for a more intense regimen. We also have treatments in the metastatic setting, so more some studies looking at bispecific antibodies in combination with chemotherapy. And I don't know if this is too
No, it's good. It's good. It's good.
much. And then we have a couple of bispecific antibody treatments in the metastatic setting right now.
I would imagine the patients are looking for more of like the immunotherapy route than the standard chemo route.
Well, I think chemotherapy is still the backbone for treatment of colorectal cancer. We're not quite ready to give that up. So a lot of our studies are adding immunotherapy agents in combination with chemotherapy.
Maybe you guys can get your little video robots to spit little
Yeah, so we actually
things at a polyp or something.
We actually have other parts of the GI tract where we put chemotherapeutic agents directly against the tumor, like in the bile duct. So yes, and if we can get our little capsule to direct itself perfectly, that would be terrific. You can work with us on that.
So you guys are gastroenterologists. You're an oncologist. I guess the only person we're missing here is a colorectal surgeon. But is that like typically the pathway, how this works? And is there a connection back? Do you need surveillance colonoscopies? How does it work once you're kind of like in the colorectal pathway?
Well, I just add that I think someone who's very important in this whole pathway is the PCP, which I think we alluded to, right? Looking for anemia, right? Which I think when I think about my patients who have been diagnosed with colon cancer, a lot of them present just with newfound iron deficiency
Like
anemia.
they show up to their primary and
your hemoglobin is now 10. And so then they're referred to my colleagues here.
And even more important is the primary. I mean, that's very important, but even more important is the primary care physician just saying you need to deal with colorectal cancer screening, because a lot of people shy away from this because they're embarrassed about having a colonoscopy. They're embarrassed about playing around with their stool for the stool-based testing. There's all sorts of reasons why people have avoided colorectal cancer screening, but it turns out to be really beneficial. So one of the few cancers that we can show where screening and then eliminating polyps, we've actually decreased the rate of colorectal cancer in this country pretty dramatically over the past 30 years. So the primary care physicians and other healthcare providers who are providing primary care, them telling a patient you need to get screened turns out to be the single most important factor in getting that patient screened.
Yeah, no, I love that. I have a primary care here at Mount Sinai, and I'm not going to say her name, but she's not like the most warm, fuzzy PCP, but she is like, this is what you have to do. Like,
who you are, by the way.
Just like gives me a bullet point list of what has to get done. And if certain things are done, the office is calling, being like, why did you cancel this? Why? And I love it. That's how they should all do.
It's good.
This is the team with surgery as well as radiation. And I mean, we have what we call tumor boards where we're presenting patients and we're reviewing in addition to with pathology, radiology, interventional radiology. So it's a big team. But I think after the completion of treatment, the core group of surgery, medical oncology and gastroenterology continue.
The people who come in either for their colonoscopy or with a stool-based test that's positive. And that's really important that if the stool-based test is positive, those patients need a colonoscopy.
So the patient doesn't even need to see you for the stool-based test.
No.
The PCP can send it and then be like...
No, in fact, on the Super Bowl, the Cologuard people were advertising just...
I love that.
In, yeah.
Yeah.
So,
just pick it up at CVS.
Well, yeah, sort of. Not really. It's a mail-in thing, but yeah.
Instacart.
Yep. But anyway, if any of those tests are positive, then we do work with our colleagues on staging, as Dr. Cohen was saying, and then we refer them typically to an oncologist to manage along with the surgeon if that's relevant.
So basically, colonoscopy, positive pathology, MRI, CAT scans, staging.
Yep.
Maybe not. Maybe just colorectal surgeon.
Correct.
Yes. Okay.
Depends.
Got it. Yeah. And I think you just brought up a really good point before. And then for those of you guys listening, one of the things that can be really stress-inducing is when you go to a doctor, get diagnosed with something, you wonder, like, should I get a second opinion? Should I get a second opinion? And especially in New York and major cities, you can feel like you need to get multiple opinions from people. And one of the great things about a place like Mount Sinai, we are an academic institution and we have multidisciplinary teams. So what they talked about is a tumor board. And you guys said your tumor board is probably similar to ours. So GI, medical oncology, radiation oncology, colorectal, pathology, radiology, everybody reviews complex cases for sure, but sometimes non-complex cases where it's like, should we do this? Should we do that? And then there's a group consensus that comes out of the tumor board. And by default, you're getting like over 10 opinions. in one visit, and that's a big benefit.
And in fact, we, for every rectal cancer patient, it's not just complicated ones, every single rectal cancer patient is presented at our multidisciplinary conference. So
yeah, that's really important because like if you're getting an opinion out of Mount Sinai, then you're getting multiple opinions that came together as one. Are you guys using artificial intelligence at all in colorectal cancer?
Ooh, that's a great question.
We are. So we absolutely are. So we're in baby step mode right now, but it's a big step where we're using it. So the easiest to explain example is that we're using it during our colonoscopies to look at the screen. So in a colonoscopy, we're looking at a video image of the inside of the colon. And as I said, we're looking for polyps. 30% of women have polyps, 40% of men, when we screen them, have polyps. So we can use artificial intelligence to look at the TV screen, and it puts a little green circle or an arrow pointing at something and says, hey, look there. And that there might be some residual stool, or it might be a polyp that I saw, or it might be a polyp I didn't see. So that's the way we're mostly using artificial intelligence right now. It's terrific at increasing the yield in polyp detection, and we're still studying whether it actually affects outcomes or not.
So far, just like when the little arrow goes up on yours, do you ever go, oh, I didn't see that. Thank you.
Yeah. So I've seen demos, and yes, absolutely. Yeah. You sort of say, oh, and we've been doing that for years also with the other people in the room. So we have technicians and nurses in the room, and we ask them to actively participate.
So other intelligence.
But now we're using computer artificial intelligence. It's very cool.
Yeah, that is really cool. Yeah, no, that's really helpful. Thank you. Yeah. In neurosurgery, when we order scans, the AI radiology reads it, and then we'll send something out. Like, so let's say it's not in the list for the neuroradiologist to read for another couple hours. If there's something that picks up, it moves it to the top of triage, which is really helpful.
Oh.
Yeah. Yeah, no, it's really, really great.
Love that.
What are some of the biggest misconceptions out there about colorectal cancer that we should talk about?
Stressing that it's no longer a disease of older people. Younger people are getting colorectal cancer.
And let's say it again. It's the number one.
It's the number one cancer death in patients under the age of 50 in the United States of America. Very big deal. And they didn't expect that to happen so soon. It was projected that this would be the case in 2030. It is now the case now. So this is a trend that is most definitely alarming, and we want everyone to know about that.
There's a myth that colorectal cancer is only a man's disease. It actually equally affects men and women. There's a myth out there that if you don't have a family history, you don't need to be screened. That's not true. Family history is important, but it's not the only thing. And most colorectal cancer occurs in people with no family history. And then the last big misconception, I think, is that if you have no symptoms, you're fine. But again, as we said, this is a preventable illness, if a preventable disease, if we can find it. And we're looking for people without symptoms who have polyps.
We got to get the polyps out.
We got to get the polyps out. This is very much akin to cervical cancer, where pap smears find cancer before it's cancer, and then you can do something about it and prevent it.
Mm-hmm.
I think the other myth out there is that colorectal cancer comes in a particular race or particular gender. There are a lot of disparities in this disease. There are patients who are getting diagnosed with this disease at far higher rates. For example, American Native Alaskan Indian patients have now the highest incidence of colorectal cancer in the United States. Second to that is for African Americans. So a lot of disparities here in terms of screening disparities, in terms of survival disparities. Not everyone is getting screened, and we really need to make a concerted effort to reach those populations that are dying of this disease at higher rates to really get the message out there.
Mm-hmm. What about you for myths?
I would say, I think you guys covered it very well, but from my perspective, I would say that it is not a death sentence. So we can still cure you if you are to be diagnosed with colon cancer. So there are really new advanced treatments out there that are curing more and more patients, even in, metastatic stages.
And it sounds like you guys aren't trying to bulldoze patients with treatments. You're trying to do like the least amount that you need to be
correct,
not as aggressive.
That is, yes, it is all about precision medicine and really focusing on the biology of the tumor and giving no more or less than what is called for.
I think it's always been there, but I think it kind of lifted a little bit more during COVID, was this mistrust of healthcare professionals, pharmaceutical companies. like some sort of conspiracy. Do you see that with any patients when it comes to chemo, that it's poison, or that there's got to be reasons that you're pushing drugs on them? Is that a part of your practice at all?
I think there is a level of questioning about, because of the side effects of chemotherapy, right? So the chemotherapy kills the cancer cells, but it also, the side effects are due to damaging some of our normal healthy cells. And the way we give it is on a certain schedule, so that those healthy cells can get better. And this is not terribly toxic to patients. But I essentially, build trust, I think, is very important, as you mentioned earlier, and explain that, really explain the studies, that after surgery, this number of patients who get chemotherapy recur versus this number of patients, which is much higher, who don't get chemotherapy. And there's a clear benefit, and that I wouldn't be giving it if it wasn't, effective. And I think, it's a matter of showing the data and reassuring patients. I think more than I think most patients are mainly concerned about the side effects more than that it's
not like mistrust.
Mistrust,
right.
Yeah. It's more about the side effects and whether they're going to tolerate it. And is the chemotherapy worse than the disease? And I always explain to every one of my patients, like, my job is to never allow the treatment I'm giving you to be worse than your disease. That's not the goal here at all. I'm here to make you better.
Yeah. I mean, because I see that in my world of neurosurgery, where sometimes people are just like, nope, I don't want to go through that. And I just will let nature take its course, and patients can make that decision. But that's so nice to hear that from a medical oncologist. Like, my goal is for the treatment to not be worse than the disease. I love that.
And I think in colon cancer, it is a disease, even in the advanced setting, where survival is, we're talking years. So it's not as nihilistic as, most of my patients do not choose comfort care, although that is always part of the discussion. If we can't cure it, that is an option to have supportive palliative care only.
Right.
And that's,
And by the way, like, palliative care for colon cancer does not sound fun. It sounds obstructive.
Well, I mean, I think palliative care is part of treatment, so I wouldn't say that, actually.
Meaning just choosing palliative care. That I mean, you say you don't get that often.
No, we don't.
Yeah.
Not without having had some treatment initially. Yeah.
I think I would just want to mention, in terms of the mistrust in the medical community, we can't ignore the fact that there were some people in this country that did undergo atrocities that really mishandled their trust in the medical system. And so to handle these communities with care, with understanding, with empathy, and to be able to have a discussion about side effects, to be able to have a discussion about treatment protocols, to be able to explain to this community, to build their trust, is absolutely critical.
Yeah. Agreed. Would you guys be able to each share a story about a patient that, like a big save, or maybe like something that was like a heartwarming story, something that the viewers could maybe be like, I got to go in and get screened?
I have a story.
Okay.
It comes to the top of mind. And I think you heard this story, Dave, at our last conference. There was a patient, African-American man. He was in his 40s, and I saw him on my clinic list, and I said, okay, I'm going to go in. I have the statistics. I know, because a lot of the times they're very apprehensive about getting screened, especially the young men. So when I went in there, he looks at me and says, are you Dr. White? I said, I am Dr. White. He said, I'm definitely getting my colonoscopy with you. And I said, why? He said, because you have your Jordans on.
Yes.
And it hit me that the connections that we make with our patients is far reaching than our degrees. It's far reaching than our training. It is the ability for the patient to connect with their physician, to build that trusting relationship. And I had no idea that my Jordans would have this big impact on this patient.
I would also feel the same way.
But he felt as though I could understand where he was coming from. That patient ended up getting screened. I found the tiniest, and I mean, to this day, I can't even believe I saw it, and it didn't look like anything, but it was a pre-cancerous aggressive polyp. And if he didn't come in, I don't know what it would have turned out to
You weren't
be.
wearing your Jordans.
I think about it all the time. I am wearing my Jordans every Tuesday in clinic for Colorectal Cancer Awareness Month, in honor of him. But it's one of those things where you never know how you're going to connect with the patient. You never know how that patient's going to decide to get screened. And these are the moments where you say, this was a life-saving procedure for you. And please go out there and tell everyone that you know to get screened, because if you didn't, this could have had a different ending.
That's a good social media story right there.
I did actually.
Good.
So I have a similar story, but I'll make it a little bit different. It was also a young man very recently, and I could do one from like every week actually.
Right.
But he was in his late 40s. He had postponed doing his colonoscopy for a couple of years because he said that he was freaked out by the prep. So I just want to touch briefly on the fact that the prep is not as bad as everybody thinks.
I think we definitely need to talk about the prep.
We'll come back to that. How about that? But this gentleman finally came in, so in 48, so he was 3 years behind our recommendations. He was perfectly prepped. Everything was good. And when I was done, I told him that I had found 6 polyps. And none of them were scary looking to me, but that we would send them off to the lab and so forth. And he looked very, very disappointed, like he had somehow failed, that he was supposed to have a perfect colon. And so I said to him, no, actually, this is exactly why we're doing what we're doing. And you didn't do anything wrong, but you had these polyps and we took them out. And much like Pascale, Dr. White was saying, this potentially, he's just going to continue on, in his life. And maybe we've prevented him from getting colorectal cancer. That has amazing impact on him and his family, 10, 20, 30 years from now. And I actually remind the nurses and the techs that I work with when we do stuff like that, what we're doing.
Right.
So that's my heartwarming story for the day.
That is. He walked out with a hop in his step because he had a squeaky colon.
Yeah, but he didn't even realize how good it was.
I'm sorry.
And it was great. And let's come back to the prep, please.
Yeah.
So I would say a little different in the sense that I treated a patient with an 80-year-old gentleman who was diagnosed basically from a dermatologist because he had a fistula. So in fact, the cancer fistulized through his skin from the cecum, and was leaking essentially. And he had seen all these doctors. No one knew what it was. He finally got an imaging and had a biopsy and was found to have colon cancer. And he was about to have this huge surgery when we realized appropriately that we tested for the biomarker that I mentioned for this marker mismatch repair. And it was deficient, which meant the tumor basically melted away with immunotherapy. So he didn't need any surgery. He didn't need any chemotherapy. And he is thriving doing...
So he just had a fistula repair.
No, he didn't have anything. It just closed up on its own.
What a win.
His own body healed it, his own immune system. So, so that's why I say there's hope in treatment.
So back to the prep. I've had a colonoscopy. I've had 2.
Good.
I had hemorrhoids a decade ago.
Okay.
Yeah, but my
very common.
Ari Greenspan is my gastroenterologist.
He's excellent.
And he said, I'm really sorry, but this is what we got to do. And that's what we did. I did not have a good experience with my prep, if you catch my drift. Did not like it. And it scared me.
Okay.
So, please tell me the prep has changed, because that was not fun.
So I don't know what you had, and we're not going to talk about that right now unless you really, really want to. Everybody drinks stuff. So most of the preps right now taste better than the preps that the comedians like to make fun of and have. I mean, their entire routine can be about colonoscopy preps, and it works. But the preps that we're using for the most part right now are a powder that mixes with some better tasting liquid. So either it's a sports drink like Gatorade or Powerade or sugar-free Powerade, Crystal Light coconut water, or a flavored solution that comes with a commercially available preparation that also tastes better. We're also using lower volumes than we used to use. So previously people used to drink something called Go Lightly. It was like 4 quarts or a gallon of seawater.
Yeah.
Terrible.
Yeah.
I mean, I've tried it. It's terrible.
Yeah.
So we've replaced that with things that are much easier to take, and because it's lower volume and easier tasting, people tend to at the end of it say, "Oh, that wasn't so bad." So you need to try again.
Yeah. I'll let you know how my next time goes. So they're just better tolerated.
Yeah, and
Is
I've
really
done,
the
I've
goal
done a
here.
couple of colonoscopy preps myself also, and they were not bad. I don't know if your experience or your patient's experience.
Only one, and it was not that bad. And I actually prepped while I was scoping. So
Yeah, I did too, actually.
Oh, you did your prep on a scope day.
I did my prep on the scope day. All right, okay, bye.
That's what we do.
Great. Do you have to prep for the video robot?
For the capsule, I mean, there is a
yeah.
prep involved in that, yes.
Because it needs a squeeze.
It needs,
to see.
well, it needs
See.
the colon needs to be as clean as it can be. Sure.
Got it.
Yeah.
Okay. So as we're finishing up, whether you want to prevent your risk of colorectal cancer or prevent it from recurring, is there anything that patients have control of that they could do to decrease their risk?
Yeah, so I think what I tell all my patients when they've completed their course of treatment and they're moving into surveillance is to keep moving. So exercise is really, really important to lower the risk of recurrence. So is healthy eating. So we talk about sort of low fat, low processed foods, red meats, high fruits and veggies, sort of what every doctor tells their patients.
Low red meat or high red meat?
Low
red meat.
Yes.
Because then you went to fruits and veggies. So I just wanted to make sure it was comma or semicolon.
Comma. Thank you.
Fruits
yes,
and veggies.
Yes. High greens, low meats, if any, and avoid the processed foods. We also make sure that everyone's vitamin D is at a good level, and avoiding alcohol. I would say in moderation, if at all, and certainly avoiding smoking.
Okay. Yeah. I mean, if you think, like, to me, I'm not in your world, but to me, common sense says decades ago, people were buying real food and prepping it at home and like eating out minimally. And processed foods were just starting to come out. Now it's like most of the foods people eat is processed, and people aren't necessarily buying whole foods and making dinner or their food every day. To me, it just seems like an obvious connection.
Yeah.
But we're just not saying it yet because we can't prove it yet.
There's a very strong hypothesis in terms of looking, when you look globally at rates of colorectal cancer. So we have a very strong correlation between ultra-processed foods and risk of cancer. So.
And then can you just define exercise for us? Because exercise to some people might be they just walk back and forth to work every day. So like what exercise are you recommending?
Any exercise, just move your body. It's not so prescriptive. There was a study looking at prescriptive exercise in terms of meeting with a physical therapist twice a week initially and then once a week subsequently for patients with stage 3 colon cancer versus giving patients just information and encouragement to exercise. And there was a significantly lower risk of recurrence for those patients who, had to show up and meet with a therapist. But it's not this specific amount of exercise. I really think it's the consistency. For patients or for all of us.
Okay. What about you guys? Anything preventative that you want to add?
The thing I would talk about is barriers. I want to break down barriers. So if we can talk about all the different barriers to people getting colorectal cancer screened, they include financial barriers, and we've tried to eliminate those financial barriers. So colonoscopy, for example, is now again free from copays and deductibles. So there's no financial barrier. The embarrassment factor. We really don't want people to be so embarrassed by stool-based tests or colonoscopy that they just don't come.
Right.
So we had a slogan that we put on taxi cabs around New York City a number of years ago that said, "Don't die of embarrassment." There are real life barriers, like getting somebody to take care of your kids or your elders that you're caring for so that you take the time to get the colonoscopy. There are a zillion barriers like that. We need to break down each one of those barriers, and they're different, as I said earlier, for different communities. And then we can sort of increase the screening rate in New York City to 70%, 80% and beyond.
Do you guys participate? Because I know that the Mount Sinai Medical School, the medical students see patients in the uninsured clinic. Do you guys participate in that from a GI perspective? That way uninsured patients can at least get in the door and then eventually get the care they need?
Yeah, absolutely. A lot of us see patients at 102nd Street, which a lot of our fellows are trained at that location, as well as the FPA, other faculty practice associates. And so we do see patients who come from right here in our catchment area, in our backyard in East Harlem, where we can serve them to see them in the clinic, see them in the office, make sure that they have choices for their screening, and make sure that they know that choice exists.
And I'll add to that, we do provide colonoscopies for the patients from that EHOP clinic that you're
Yeah.
talking about who have
Thank you. I
positive
remember that.
screenings,
Yeah.
and they need a colonoscopy. We bring them absolutely in, no charge, everything's taken care of. Yep,
That's great. That's
appropriately.
great.
The way it has to be.
Yeah, it should. It has to be. Thank you guys so much for being here. I really appreciate your time.
Thank you.
Thank you.
That's all for this episode of The Vitals. I'm your host, Leslie Schlachter. Subscribe to The Vitals and the Mount Sinai Health System's other video podcast programming on YouTube, Apple Podcasts, Spotify, or wherever you get your podcasts. To learn more about colorectal cancer treatments or to book an appointment with a Mount Sinai expert, scan the QR code below on your screen or click the link in the description below. To get in touch with the show or to suggest an idea for a future episode, you can email us at podcast@mountsinai.org.